This podcast is produced by the Center for Deployment Psychology at the Uniformed Services University of the Health Sciences. The views expressed are those of the speakers and do not necessarily reflect the opinions of the Uniformed Services University, the Department of Defense, or the U.S. government. In addition, references to any specific companies, products, processes, or services does not necessarily constitute or imply endorsement by the Uniformed Services University, the Department of Defense, or the U.S. government. Welcome to CDP's podcast, Practical for Your Practice,
where we give you actionable intel to support what you do.
One colleague to another. Welcome back to Practical for Your Practice. I am Jenna Ermold, and as always, I'm joined by my fantastic colleagues, Dr. Andy Santinello, Dr. Kevin Holloway. You want to say hi, guys?
Hey, how's it going?
It's exciting. I'm excited today. I got to tell you, we have a fantastic guest who is Dr. Shannon Miles, and I met Shannon a couple of years ago when she presented in our webinar series. The title of her webinar was Understanding and Managing Anger and Aggression in PTSD. And as we were developing the podcast, she rose to the top of names of folks I wanted to have on because she did a fantastic job in the webinar and I think has such important practical applied things to share with all of us about, when anger and aggression is part of the clinical picture. So Shannon, welcome so much. We welcome you to the podcast, and maybe you could take a second to, give us a little bit of your background and what you're doing these days.
Absolutely. Thank you so much for having me. I'm excited to be here. I am a clinical psychologist at the James A. Haley VA, which is located in Tampa, Florida, and also assistant professor at the University of South Florida, which is our academic affiliate right across the street. However, I'm not here on behalf of either of those organizations.
And Andy and Kevin, you might not know this, but Shannon's dissertation was actually on disgust. So I kind of think she says she researches shame and vulnerability, and they kind of like walk away slowly. I feel like Shannon is like, yeah, I talk about anger, aggression, and disgust. And I wondered, like, do you make friends easily at
well, she's
cocktail parties?
She's comfortable with disgust, so that probably opens up a lot more possibilities for her in terms of who she can relate to.
You'd be interested in how many people love to talk about their disgust triggers. It is rather eye-opening when you study that topic.
Yeah. So maybe we'll have part 2 on disgust. But today we really wanted to talk about, your primary line of research, which is anger and aggression. And I guess partly want to start by saying, anger sometimes gets a bad rap. And, maybe just start by when you're talking to other clinicians or in some of the work you've done, maybe let's set the stage about emotion in general and all the different ones, and whether they're bad or good or neither.
Absolutely. So it's interesting because I did start out in disgust with an affective neuroscience background, but it became clear that disgust is one emotion that can really cause challenges for people with OCD, with certain phobias, but oftentimes people have trouble regulating a variety of emotions, especially people who have served in our military and have developed PTSD. And so my background started to explore these different emotions. So anger and disgust and sadness and happiness and fear, which is another topic that can often bring up anger and discussion or anger and aggression. And so it's this blend of emotions or these variety of emotions that give us joy in life and so much excitement and the ability to be humans, but also can cause a lot of impairment and challenges for people. What brought up anger and aggression for me was working with patients who had post-traumatic stress disorder. And it is such a common problem within that disorder specifically. It's actually one of the most reported challenges that people come back from deployment and want help with across psychological disorders. So it's not specific to PTSD, but it's definitely present frequently in PTSD.
And for people who are experiencing those challenging emotions that, they're really frequent with PTSD, how do you find it, interacts with maybe help-seeking behavior or taking advantage of resources that are out there, that kind of thing?
Well, oftentimes I find that patients present when they have a lot of anger and aggression because their spouses or loved ones or partner said it is time for you to go get treatment or I'm done. And so oftentimes it's the consequence for the other party that brings them in, and they value that person enough or that family member or that unit enough to say, okay, I'm willing to change things. Anger and aggression often feel pretty good for the person who's experiencing them. So it generally is not just the internal experience that they want to help manage. It works for them. It can be really empowering. It can feel a lot better than fear or shame. And so anger has a lot of adaptive qualities, as Jenna said earlier. We need anger. We need it to keep us alive. We need it to adapt to our environments, to overcome obstacles. We definitely need it within a military system. However, we need to be able to regulate it and target it in appropriate fashions. And so oftentimes there's this balance between recognizing how important these emotion systems are for survival, and not only for humans, but for mammals, but then also like, how do you function and how do you transition between environments in a way that allows you to still connect interpersonally?
I think it's a really important starting place for a strategy for working with anger and aggression, the normalizing of anger as a valid emotion, and the fact that there's nothing wrong with being angry. So much of our ideas and thoughts about anger put it in sort of this negative category. It's bad. We shouldn't have it. So many clients come with that belief. And as you just mentioned, family members talking about, I want you to get anger management, when it feels really empowering. And one of the things I was curious about, and I know you're going to probably get to this eventually, but the difference between your work in aggression management and regulation and anger management, because I think there's a really important distinction between those two things.
Yes. So just a lot of points there, Andy. I do think culturally, and especially depending on where you were raised, that there are different values with emotion systems in general, and also gender specific. So being raised in the South, anger is not an emotion that girls or women are encouraged to have. In fact, that is often taught to be inappropriate. Now, on the flip side, men are actually allowed to be angry, and they're allowed to express anger, and that is generally more socially accepted than it is for women. And so one of the things that we do in treatment is to talk about the adaptive qualities of emotion systems, but also to talk about where your beliefs started. So were your parents accepting of emotions? And oftentimes for men, unfortunately, it is suck it up, don't be a girl, and like put those feelings down and carry on. And then for women, by God, it better not be anger, because that is inappropriate. So about your emotion systems and how you're allowed or not allowed to have them in order to address your secondary emotions to those primary emotional experiences. So that is part of the work that I do, and anger management can be really helpful. So I am in support of that. But one of the things that I found lacking when I was working with anger management is that it's not just anger. Like, we are these full functioning human beings or mammals that have all of these emotion systems. So if you focus on one, that can be helpful. But it's part of the story. We now know that emotions can elicit other emotions. So shame is one that often elicits or can elicit aggression. And so if you're feeling shame-based emotions, and aggression can be one way to change your status in a social hierarchy, that is one way to elevate you and make you feel better. So if you ignore the shame part, you may be ignoring what the actual problem is, or the initial core emotion. Example, fear. Fear is so helpful. It keeps us alive. It allows us to survive. But one of the very typical responses to fear is the fight response. And so if you're fighting, that may help you survive situations, but it's not so much the anger, it's the fear that triggered that aggressive response. So really kind of getting down to, it's not just one emotion that causes challenges. We are emotional human beings, and how do they interact, and how do we help you regulate them?
I think that's a distinction sometimes that gets blurred, that, you have the emotions, anger, fear, shame, and the behavior is aggression, and they're very different. I think sometimes people combine those two things. Anger and aggression are like the same thing, and that's where we miss the boat.
Oh my gosh, this is such a good point. And oftentimes patients do not distinguish between the behavior, the aggression, the yelling, screaming, throwing, and the actual emotional response. So if that's anger, first, or if it's fear or whatever the triggering emotion is, oftentimes patients need to be taught, like, emotions, you have them, they're automatic, you have to regulate them, but oftentimes you don't have control over them. What your reaction to them is the important part. And even in anger management and aggression treatment that I do, the anger often doesn't change. And that's okay. We want you to have anger, but it's your reaction to that anger is what we want to change. And it doesn't matter if it's psychotherapy or medication. You're going to have anger because you're a human or a mammal. And it is your responses to that we want to help you change.
So interesting, because I've seen a number of clients that will come in and tell me that they've got an anger problem and they need to have anger management therapy. And when we explore a little bit about, what does that give rise to? What behaviors does that lead to? It usually is things like shutting down, or it's like, or, like they'll talk about how they almost did something really shocking and aggressive, but, and so they feel like they need to get rid of this anger. They need to kill this anger off, so that they don't do something crazy. And it comes, I guess, into stark relief to me when I'm talking to those clients, the difference between the emotion and the behavior there and how important that is.
Yes, so important. And the people, and with PTSD, there are two symptoms that we look for. It's these strong negative emotions, that be anger, guilt, sadness. But then aggression is actually measured in a separate symptom. And when they say, "Oh, I was so aggressive, I didn't know what to do," I'm like, "Oh, what did you do?" And I sat there and I didn't say anything for like 30 minutes. Well, you're really angry. And I hear you, but that's not aggression. And that's actually a sign that you're controlling your emotions.
Yeah.
Maybe not the most adaptive way to control them, but you're not throwing things, you're not screaming. So that's a pro. That's a benefit.
As you're talking about it, one of the things I'm sort of thinking about is, conceptualizing anger and other emotions like shame and fear and things that can precede aggression is almost like antecedents. I think often as clinicians, we think about those emotions as responses to a trigger. And of course, they could be in sort of the behavioral chain, but it just even shifting the focus towards thinking about, okay, you're angry. You may not have control over that. It's not like you're doing something wrong. You just happen to be angry. Now, what's your response to that anger really can, I think, shift that conversation to something different. Because then there could be shame about being angry,
Right.
If you don't make that shift, and then that could lead to some other things too. So it's just, I think, a really sort of subtle but very important shift in thinking that could be just right off the bat useful for clients.
Absolutely. And that really goes with any type of psychotherapy that wants you to practice acceptance-based thoughts and emotions. So like not having a secondary emotion to your emotions is so important, and really can be freeing if you're allowed to just be angry and not have to have all these other guilt and shame related to that normal response.
Because try not to be angry when you're angry. Good luck with that.
I love when patients say, "Oh, my wife or my partner or whoever just told me to get over it." I'm like, yes, that works. That works. That's such a helpful statement.
Right. Works 0% of the time.
Right.
And yet we all still, at least myself, I tell myself those same things, all the time too. Like if I'm feeling something that I don't like, I'm telling myself, okay, well, you need to just get over this and do something else, instead of, allowing that to be where it is. And
in particular with things like anger and shame, when anger and shame shows up, it's because something usually feels very threatening and violating. And then to say to yourself or have somebody else say to you, it's no big deal, just make you even more angry and feel even more invalidating.
It usually comes from a good place when people want to help, and people often just don't know how.
So I think that was, some good points about maybe what's not helpful or what's not going to promote better mastery of that aggressive behavior. So maybe we can shift gears. And I know that you are PI on an RCT for an intervention, manage emotion to reduce aggression. I think I got that right, MERA.
Yes.
And would love to, hear more about what we would recommend that clinicians do. This podcast is really intended to kind of support our colleagues out there to do better jobs in their practice. So thoughts about that would be great. And one distinction I've heard you make before that I wanted to also talk about was impulsive aggression versus premeditated aggression, and kind of what works for each of those, or maybe what doesn't work for a certain kind.
Perfect. Yes. So I'll start with impulsive versus premeditated aggression. So it is important to recognize as a clinician that all aggression is not motivated by the same thing. So we've already talked about how it can be triggered by different emotions, but there are also different types of aggression. And impulsive aggression is when you lose control. It is an overreaction to the trigger. And oftentimes people report regret after the behavior. So a perfect example of this that really got me started in this line of research was I was working with a client who did not present aggressively to me. He was respectful. He was on time. He did his homework and he was working on PTSD work. And he came in one day and talked about how his young child spilled something. I think it was milk, something trivial, and he lost it. So he screamed at him and he didn't remember what he said. There's often like this memory gap for details. But he scared his child so much that the child urinated on himself. And I remember just like sitting there in session one, being so sad for his child, but also being so sad for my client because it was so inconsistent with who he was in terms of his values and who he wanted to be as a person and as a father. And like, he was very distressed. And it was just so incongruent with the person that I would meet with weekly. That is impulsive aggression. That is losing it. It is out of control. It is not planned. And people often want to change that behavior. That's what brings them in. Now, you can compare this to premeditated aggression. That is planned, deliberate, and not emotionally driven. So in the room with patients, you can feel qualitatively a difference. One person is reporting remorse and regret. The other person often says things like, well, I warned them and they deserved it. Or if, I said X, Y, and Z and she didn't back off, so she got what was coming to her. Statements like that. And this lack of emotional engagement, it's very matter of fact, like aggression works for me. We can treat impulsive aggression. That responds to medications like anti-epileptic medications, mood stabilizers. Sometimes SSRIs are used, and psychotherapies. We don't know how to treat premeditated aggression because it's deliberate behavior that is often working for the person. So one of the things as a clinician is you need to figure out what type of aggression first. Is it impulsive? Does the person value whatever family unit or whatever thing in their environment enough to change it? Or is it premeditated and it works for them? Usually there's a feel, but there are also measures you can use to get at that. The impulsive premeditated aggression measure is one option. So what is motivating the aggression? I target or I focus on people who have impulsive aggression. And
that's more common with PTSD, right? Impulsive aggression is what we're seeing more when we're seeing that with PTSD.
Yes. Thank you. So about 70% of people with PTSD report aggression. That's a lot. And this can be yelling, screaming. Often it's verbal aggression, but about 20% of people after they return from combat with PTSD report engaging in violence. And so an action that hurts another person. And so it's a huge problem. Most of the time, the vast majority of that aggression in PTSD is impulsive. And so it's oftentimes not premeditated, it's impulsive, and you can work with that. Patients want to work with that. They want to decrease that behavior. Absolutely.
The way you describe premeditated aggression sounds also a little kind of axis to characterological, and it makes sense why that would be a little resistant, I think, or not just a little resistant, but resistant to intervention attempts differently perhaps than the impulsive aggression. I don't know if that's a distinction you would make, but that was the flavor I got as you were describing them.
Yes. And similar terms are used for, or different terms are used for similar constructs. And so sometimes people label it as antisocial PD. However, you don't have to be fully antisocial to have premeditated aggression. Some people just like being aggressive. And so that is harder. And actually those people respond less well to anger management. So in treatment, they tend not to do as well because the behavior is working for them.
Yeah.
So as a provider, being able to distinguish the two types of aggression, and then in terms of the treatment that I provide, MERA, Manage Emotions to Reduce Aggression. This is a skills-based treatment that does a couple things. One, it's delivered in 3 sessions because people who have PTSD have high rates of dropout from treatment. If they are going to drop out from treatment, you generally have 3 sessions with them. And so it is a 3-session treatment because that's how long we were keeping people in treatment. And we said, okay, if we can only have them for a limited amount of time, what is the most impactful thing that we can do for these people who may not return to clinic for years and years? And so it's also very skills-based, which means that it gives people tools to deal with their emotions, but it's not going to fix everything. You're going to give tools to help them adapt to their current lives, but they're probably going to need other types of psychotherapy. And what happens is that we teach them the adaptive value of emotions. Emotions are there for a reason. They help you survive. They're signals to other people. They help you get away from danger. They help you overcome obstacles. They help you engage in life and procreate. They help you from getting sick. Discuss where I kind of started this line of research. So all of these things are very helpful and adaptive. We have to recognize that. And then we say, okay, how do you actually view them now? Do you view them as adaptive? And if not, why? Like, what was your upbringing? What was your military culture that you engaged in? Or first responders tend to have similar emotional responses as well. Gender tends to play a role. And so where did those thoughts come from? And now what do you do with it? And we teach 8 skills. These skills are not new to the treatment. Any provider that has worked with skills-based treatment, either cognitive behavioral therapy, DBT, or ACT, you can get these skills. And we wanted this treatment to be feasible for providers in many different clinics in many different settings. And so there's an app, the PTSD Coach App has this, all of these skills, or you don't have to use the app because some people don't like apps. Some people do. And it teaches veterans to bring up those emotions, which are adaptive, and then regulate them. And you have to do it with them in session because it's a practice that you have to do repeatedly in order to become skillful at it. And then you practice in multiple different settings. And so this is not groundbreaking work. The delivery is new, and the adaptive perspective of emotions is kind of new, or maybe not delivered as frequently as I would like, but it's teaching people what to do with their emotions. So it's kind of a simple construct or a simple idea. It's just delivered in a way that veterans were allowing us to deliver it, which is brief, 3 sessions and very direct.
So Jenna said you're the PI of an RCT looking at MERA. And I assume this isn't the first time that it's been studied or looked at it and kind of results, but like, what are you generally seeing? What the kind of impact?
Yes. And so we ran a pilot study with MERA to make sure there was a signal and to collect safety data to make sure we weren't making people feel worse with the treatment. And we had a positive signal. So after 3 sessions, we had a moderate effect size at reducing aggression. So veterans reduce their aggression generally by half and also reduce their emotion dysregulation. So we actually think that's the mechanism that is helping people reduce their aggression, is regulating their emotions. And so we found moderate effect sizes for both of those, aggression or frequency of aggression, and then amount of dysregulation. That's a pilot study, so you really shouldn't be looking at effect sizes from such small samples, but it allowed us to provide a proof of concept, and we are beginning our randomized controlled trial now that compares MERA to present-centered therapy. So if you get 3 sessions, you may not be doing EBP, you may just be providing support and problem solving. And so we are starting that at the Tampa VA and at the Houston VA, and we don't have results for that yet, and it will be blinded, so it will take an extreme amount of time to get the results. It's a 5-year study, but we are hopeful that it helps people manage their aggression.
That's so exciting. And it's early on, of course, and we've got some preliminary, good news there. And I don't know if one of the things I think that a lot of our listeners, or at least those interested in treatments and interventions, especially evidence-based ones, is, and I can almost imagine, because I'm thinking this too, like where do I sign up? Like, are we at a place yet where MERA is being disseminated, and how does somebody implement that?
Yes. So I am very happy to share the manual. The Department of Veterans Affairs, your tax dollars paid for that manual, so you can have it. Please feel free to email me. We are editing it and updating it for the RCT. And so I'm happy to share it with everyone. Actually, it's been disseminated throughout the DoD at 17 training sites. And so it's not a mandatory part of training, but for psychology and social work programs, it is being offered to students as an option for their service members who are presenting with aggression. And so happy to share it. And some people are using it. I just don't want to oversell the results before the science gets there.
Yeah.
And I guess one question I had was, would you see this as a good, Kevin and I both teach PE, and he teaches CPT and ACT. Is this something that could be helpful, like before you would start an EBP, to kind of get a client to a place where they might be able to digest the
Like
EBP a little bit
preparatory.
better? Yeah, kind of preparatory. Thank you, Kevin.
Yes. And so this is developed to go before CPT or PE. So I love CPT and PE. However, the rates of dropout are just really high. They're up to 50% in clinical settings. And so we actually did qualitative work with veterans, and we said, what is your biggest fear about engaging in PE and CPT? And these are veterans who actually finished evidence-based psychotherapies. And they said, I didn't think I could handle my emotions. I thought if I opened it, I wouldn't be able to manage it. Now, as someone who does those treatments, that's inaccurate. That's a fear, that's a cognition that's inaccurate. However, if the patient doesn't realize it's inaccurate and you don't convince him or her of that, you get 3 sessions. And they're gone. And they may need skills-based, but they also probably need PTSD work. And so it's one way to hook them into treatment. And that's an exploratory aim of the RCT, is if we offer them MERA, are they more likely to initiate an EBP? And so we'll see if that pans out. We hope it does. And also, even just that therapeutic relationship, developing that, helping the patient feel or the client feel more comfortable, is enough to have that little building block to get them to trust you enough to do an EBP, which can be scary.
Well, we really appreciate you spending some time chatting with us today. And we always like to end our episodes with just a couple of pieces of actionable intel. So some thoughts or advice that clinicians who are listening to the podcast today and maybe are encountering impulsive anger and aggression with the clients they're working with can use and put to use right away. So do you have a couple of thoughts about maybe 2 or 3 little bits of actionable intel that our users could make use of?
Yes. One, it's to become comfortable with your own emotional experiences. So if you are uncomfortable with your own anger, or you're uncomfortable with your own sadness, that can be really difficult for you to handle someone else's. I think as therapists, we are comfortable handling other people's sadness and distress or anxiety, but anger is so jarring. Aggression is so jarring, especially if it's directed at the therapist, in the sense that the patient is angry and doesn't know where else to deliver it, and you're in the room with him or her. So being able to regulate your own emotions is really important. These skills are not just for PTSD. The app is great. Everyone could benefit from using it, the PTSD Coach App. And so becoming comfortable with your own emotions, but also being comfortable when people are aggressive. It can often trigger aggression in you. And I have botched my response to aggression, like in any way you can. I've been too passive. I've sat there and taken it when I should have set better boundaries. I've been too aggressive. So if you can botch it, I've botched it in any way. However, being able to be around it, and the more you're around it and realize it's not about you, but it's about this person's experience and being unable to regulate what is going on internally, kind of taking a step back and looking at it from that perspective can be really helpful. And so regulate your own. And then also, when it comes up in session, it's generally not about you. And if it is, then y'all work on that in treatment. But that can be really jarring, especially for new therapists who are not used to having that type of behavior directed at them. And then I guess, so becoming comfortable with one's own emotions and other people's emotions, that's kind of like therapy in general. But also being able to give skills even if you have a limited amount of time. So I used to have this practicum supervisor who said, you want to give your patient a parting gift. And this is Joanne Davis at the University of Tulsa. If she ever listens to this, she said, you always want to give your patient a parting gift. And if that is a skill, that is awesome, because they can take that with them and use it. And so oftentimes when people don't like EVPs, they talk about how step-oriented it is and all these other things that you have to follow. But having tangible things that people can walk away with instructions is helpful, especially if they're so new to the area of psychotherapy. And so feeling like you can follow skills-based or give skills-based intervention, I think is really important.
Great. Well, I knew you would not disappoint, Shannon, and you did a fantastic job. It was a great discussion on aggression, and we'll definitely in the show notes be able to put some information about how folks can try and get more about the therapist. There's a therapist and patient manual for MERA, correct?
Correct. Can I just give that to you guys? Like, is there a way to post that? Like, I don't know if that's allowed or.
We can see what we can do.
Okay.
We might have to work those details out, but I know that I speak for the three of us when I say we really enjoyed the conversation. Thank you for the actionable intel for sure. And
parting gift.
Maybe we will have a future discussion about disgust. I don't know.
Yeah, I can't believe you pulled that one out. Jenna, I didn't even remember us talking about that. I was like, wow.
It's like I'm an elephant, Shannon.
Noted.
So thank you very much. And we hope you listen in again for our next episode of Practical for Your Practice.
Thanks, everyone.
Thank you so much.
Yeah.
I really appreciate it, guys. Thank you.
Thanks for listening to Practical for Your Practice.
Please feel free to subscribe, rate, and join in on the conversation in the comments.
Until next time.